Thank you for joining the breakout room, and I think some of this will be tantalizing, and this is a bit of a sneak peek or an early look at the Canadian Cardiovascular Society, Canadian Heart Failure Society guidelines for heart failure. Heart failure in particular for people living with non-reduced ejection fraction, and I'll explain why I'm using that very deliberate kind of funny terminology. But this is half of people who have carried a diagnosis of heart failure at some point in their lives, and has been a long-awaited treatment gap. So I'm looking forward to some engagement, and we'll have lots of time, I think, for questions and discussion at the end. When I say this is a sneak peek, this is truly hot off the press. This is going to be in print in about a week's time. So you're getting an early look at this, and more feedback to come, I'm sure. But I do want to introduce the speakers. I'll be kicking things off. I'm Mike McDonald. I'm one of the clinical cardiologists at the Peter Munk Cardiac Center, and also work at Mount Sinai Hospital. And I'm the medical lead for the Advanced Heart Failure and Transplant program. I'm here in a couple of capacities. One of the capacities is I've been involved with the Canadian Cardiovascular Guidelines program for over a decade, and I've chaired past iterations of the guidelines, so very privileged position. I'm going to introduce next my colleague, Dr. Natasha Aleksova, also well known to most of the group, and she's got a long bio. I'll summarize some of the highlights, but she's Canadian trained and works with me as a close colleague in the Advanced Heart Failure and Transplant program, and she's gone on to do her master's in clinical epidemiology at McMaster, health research methodology at McMaster, and has an active research portfolio in all things related to heart failure care and post-transplant care. And then finally, it's my pleasure to introduce Anita Shilton, who I've met electronically until about 5 minutes ago, and now nice to meet her in real life. And Anita's going to wrap the session up, providing her perspective as a person with lived experience with this particular condition. And Anita has been a leader in coaching and organizational development, and she has experience in the public and private sectors at a whole bunch of levels, and was actually the Dean of Continuing Education at what was then Ryerson University, now TMU, of course. And she really advanced the quality mission for internationally educated professionals. And now she leads her own coaching practice, volunteers as a coach for women in transition, and has shared that despite living with rheumatoid arthritis and atrial fibrillation and this history of heart failure, she is very active. She's a golfer. She swims, cooks Mediterranean food, and spends time with her granddaughter. So I'm delighted that she could provide her slides and context to the guidelines. So without further delay, no relevant disclosures for our presenters today. So I hope in the next 40 or 45 minutes that we can provide the rationale for a guideline update for patients living with heart failure and non-reduced ejection fraction, describe the methodology used to develop our guideline recommendations, which are evidence-based, and that is key. And then think about how we apply the current guideline recommendations and emerging evidence for the management of patients with this condition, with heart failure and preserved or mildly reduced ejection fraction. So a little brief timeline. If we look back in recent history of where major guideline updates have occurred, there was a big comprehensive guideline of all things related to heart failure back in 2017, put out by the Canadian Cardiovascular Society, and then in 2020 there was a more focused update on emerging evidence for dealing with functional mitral regurgitation, the emerging role of some pharmacologic therapies, and the emerging management of a condition called amyloidosis, with which many of you are familiar. And then in 2021, we had our big revision of the guideline for heart failure with reduced ejection fraction, and that was really reflecting a new standard of pharmacologic care, and I was very proud to be part of that effort, and that has had international impact truly, and I really think our approach to treating that condition has translated to many lives saved and life years added. So what did the original big guidelines say about this 50% of people living with heart failure and preserved ejection fraction? Disappointingly, not a whole lot. So if we look back at standard of care recommendations, there was some lukewarm recommendations for an angiotensin receptor blocker, candesartan, to reduce heart failure hospitalizations. Okay. Treat hypertension according to guidelines. Sounds like a good idea, but not highly specific. And consider spironolactone, which is our mineralocorticoid antagonist of choice for this condition. So not a lot on offer, and disappointingly so, given the numbers of patients that we're all caring for with this condition. So why do we do a bit of a refresh and really focus on pharmacologic therapy for people with non-reduced ejection fraction at this time? Well, again, historically, most of the trials in this space have been somewhat disappointing with neutral outcomes, and we can discuss why the reasons for that might be. But recently, there's been a little bit more cause for optimism, some real impact with some of our pharmacologic therapies for non-reduced ejection fraction heart failure, specifically SGLT2 inhibitors, mineralocorticoid antagonists, angiotensin receptor and neprilysin inhibitors, or ARNIs, and then the GLP-1 receptor agonist story that you've heard about already a little bit this morning. And we were also answering a need or a gap because clinicians have been asking for these guidelines. And again, it impacts about half of the patients we look after with a history of heart failure. And we recognize that a big driver of morbidity and ultimately mortality is the number of hospitalizations that this population of patients can experience, and this burden of hospitalization is vexing and is a good target for intervention. So back to the terminology that generated a lot of debate. When we say that somebody has a condition with heart failure and reduced ejection fraction, we get sort of 10 out of 10 cardiovascular specialists agreeing on what that is. That's an ejection fraction less than 40%. Here's where it gets debatable and awkward with the terminology. It's sort of anybody without that category. So if your ejection fraction is over 40%, there is data to support improving outcomes depending on where the ejection fraction sits in that continuum. So non-reduced EF is everybody living with a history of heart failure and an ejection fraction above 40%. By convention, if your ejection fraction is 50% and over, we call that preserved, because that's the lower limit of normal in most population samples. And then if you're 41 to 49% ejection fraction, which is a level of precision that sometimes is not even offered by our imaging techniques, you have mildly reduced ejection fraction. So we've put this under the umbrella term called non-reduced ejection fraction. It's very Canadian of us. You won't see this nomenclature anywhere else, and you might not even like it, but that's what it is. I'll just turn it over to Natasha on my next slide, but here's what the panel looks like. The names are not so important, but this reflects that it is a team sport. It is a massive team sport, and the writing panel consists of academic and community cardiologists, internal medicine specialists, research methodologists, nursing, pharmacy, and proudly people with lived experience, which is uniquely Canadian in our approach to guideline development. So over to Natasha just to walk through how the guideline process works and why we've got evidence-based recommendations.
Thanks, Mike. So basically, the process has to begin with the questions. And as simple as that sounds, establishing what is the population we are going to address in this guideline, what is the intervention, what are the comparators, and what are the outcomes is the most important point on this slide. Because without that, the next steps can become very messy. So that's what we did, and I'll show you our PICO questions exactly. We then conducted a systematic search. We identified studies that were included. We conducted risk of bias assessments, did appropriate meta-analyses for all of our a priori outcomes of interest, and used this framework called GRADE, which I'll speak to in a second, to basically take our evidence, turn it into recommendations, and then blindly vote on those recommendations by all writing panels who did not have an important conflict of interest for that question. So what are the questions? Well, the key thing here is that the population and the outcomes are the same across all of our questions. So we wanted to know about all people with symptomatic heart failure who have an ejection fraction over 40%. And the outcomes of interest, whether we found them in the studies or not, that was not the point. We established them up front to be all-cause death, cardiovascular death, heart failure, hospitalization, symptoms as described by NYHA functional class, functional status as described by the 6-minute walk test, and quality of life metrics as described by the KCCQ. So our first question asked of the intervention ARNI or sacubitril valsartan and comparing it to placebo, ACE, ARBs, or no treatment on the top of background medical therapy. And for all of our PICO questions, what you'll see at the bottom is we identified upfront what are subgroups of interest or subcategories where we may want to understand if the treatment effect might differ according to that subgroup. So after our first PICO question, which was around ARNIs, we wanted to understand whether the intervention GLP-1 receptor agonists compared to placebo on top of background medical therapy, what the effect of that was for our outcomes. And we, again, identified subgroups of interest upfront, including sex, ejection fraction, BMI, and the presence or absence of diabetes. A similar theme here, very structured approach, but this really allows you to conduct the next steps properly. So the third PICO was regarding SGLT2 inhibitors, and we, again, compared it to placebo on top of background medical therapy, and the subgroups of interest similarly are there at the bottom. The last PICO question was regarding mineralocorticoid receptor antagonists, and I think it's intentionally put there that we didn't a priori consider non-steroidal versus steroidal MRAs, so there was really no distinction made up front. And the subgroups of interest for this PICO question were similar to the other PICO questions, but did include, in addition to sex and ejection fraction, type 2 diabetic, albuminuria, chronic kidney disease, and geographic region. So by having these PICO questions and going through that process I outlined, we ultimately wanted to use a GRADE framework. And so what is GRADE? GRADE refers to grading of recommendation, assessment, development, and evaluation. And what this is intended to be is a transparent, and that's the most important thing. A guideline at the end of the day will still be some people coming together over other people who are not going to be there, and it's always going to be a selected group of people with their values, preferences, and opinions there, but it's intended to be transparent. So it's a transparent framework for turning research findings into evidence-based decisions in guideline development, and it really comes down to two key components. One is you grade the evidence, and two, you grade the strength of the recommendation, and I'll explain what I mean. So in terms of grading the evidence, what we're really talking about is, first of all, you want to establish what is your initial level of confidence? And for the purposes of this guideline, we uniquely looked at randomized controlled trials. And so by default, we start with high confidence in our evidence. And then we move on to the second step, which is, will we lower or raise our level of confidence based on certain considerations? And when it comes to randomized trials, you start high and you may lower your confidence in the evidence based on things like the risk of bias, whether there's inconsistency in the result, whether the results directly or indirectly apply to our patient population, whether there's imprecision in the results or publication bias. And lastly, then, you come together to have a final level of confidence, and that can be very low, moderate, or high. And then the second part of grade is to actually grade the strength of the recommendation, and your recommendation can be strong or weak. And when you think about what makes a strong recommendation, well, really, what you're trying to establish is that the benefits outweigh the risk, the hassle, the cost, or vice versa. And what are the drivers of a weak recommendation? Well, these are those situations where there's a close balance between benefit and harm. Perhaps there's a lower confidence in your estimate of effect. Maybe the values and preferences or costs are too important to not consider. And this slide is busy, but what it shows you, and what I want to kind of get a point, is that the evidence to decision framework, or how we make a recommendation when using grade, relies on more than just the certainty of the evidence. The certainty of the evidence is very important, don't get me wrong. However, there are other components of the decision that, as long as you justify and explain, are part of the framework. And they include things like, is the problem a priority? What exactly are the desirable and undesirable effects? I didn't discuss it in our PICO, but we did look at safety outcomes when we evaluated each of these interventions. How much do people value the outcome? What are resources required, if that's applicable? Is this equitable? Is this cost effective? Is this acceptable to the patient population of interest or to the general population and stakeholders? Is this feasible? These are all components of the framework that lead to 4 options for grade when it comes to making a recommendation. And the first is strongly in favor. What that really means practically when you're speaking to a person who would qualify in the population of interest for a specific recommendation, is that a recommendation that is strong means that almost all informed patients would choose the intervention. Whereas weakly in favor means that, it's a collaborative decision. You have to discuss it with each individual patient, and perhaps in certain circumstances, a specific intervention would make sense, but in others it may not be so clear-cut. And similarly, you can have a recommendation that is weak against or strong against a specific intervention. So we'll move on to the actual recommendations by starting with a case. And this is based on a compilation of many patients in my practice. And it's a 70-year-old woman who recently was in the emergency department for decompensated heart failure. And here I put HFpEF, but heart failure with non-reduced ejection fraction. If you see heart failure with preserved ejection fraction, for the sake of this talk, they're interchangeable. This particular patient had poorly controlled hypertension and chronic kidney disease, was on some medications, examined a bit volume overloaded with slightly elevated blood pressure, and had echo findings in keeping with the condition at hand, and biomarkers that were suggestive of congestion as well as chronic kidney disease, as outlined. So really the question we're asking, is there a role for additional pharmacotherapy? And specifically, I'll speak to the first 2 of the 4 PICO questions, asking how strong is the evidence for mineralocorticoid receptor antagonists and ARNIs in this scenario? So I won't belabor this point. To some in the audience, you may be aware of one of the landmark studies that's a decade old that looked at spironolactone, a mineralocorticoid receptor antagonist, in over 3,000 patients with symptomatic heart failure and an ejection fraction over 45% that met other specific criteria. And the outcome of interest was a composite of cardiovascular death, aborted cardiac arrest, or heart failure hospitalization. And the bottom line is that when you looked at the composite outcome, there was no difference between the intervention and the placebo. However, when you focused on just, and that's what the rightmost figure shows, on heart failure hospitalization, there did seem to be a reduction in heart failure hospitalizations with spironolactone. This study has been criticized and debated and evaluated in many different ways, but bottom line, there was some question around perhaps certain patient populations may benefit more from the intervention, such as those with an elevated natriuretic peptide, or those from a geographic region where the investigators believed they really did have the disease of interest, and that's what this slide kind of highlights. So this, for the sake of time, allows me to get to the other key, and not only, but key randomized trial that we included in this guideline. And this study is called Fine Arts HF. It randomized double the patient population as the previous study I showed you, and made some key distinctions in the patient population by including people who had structural heart disease. That was a necessary requirement to be included. They did have a primary outcome that was a composite of worsening heart failure events and cardiovascular death. And in the figures at the bottom, what you see is finerenone, which is the drug of interest. It's a type of mineralocorticoid receptor antagonist, was associated with less of the composite outcome, but this was primarily because it was associated with less heart failure hospitalization, and that's what the figure on your right shows. Those are just highlighting a few of the key studies, but what we did was for all of our outcomes, we created these forest plots, which basically summarizes our evidence. And in the top, you see that for cardiovascular mortality, the effect of mineralocorticoid receptor antagonists was such that there was a possible benefit to this medication. However, the confidence interval, meaning we also suggested there may be harm or it may favor placebo, so there's uncertainty around whether cardiovascular mortality would be improved with mineralocorticoid receptor antagonists. At the bottom is the forest plot for heart failure hospitalization. And here what you see is when you take almost 10,000 patients and determine which ones had a heart failure hospitalization event and which ones didn't in the MRA and in the placebo group, what you get is a point estimate, or what is the effect. And what we found was that you reduce heart failure hospitalizations with mineralocorticoid receptor antagonists, and our confidence in that was such that it didn't cross that line, meaning it was favored compared to placebo. So to take months and months of work and put it into one sentence, this is what we came up with. So for people with symptomatic heart failure and an ejection fraction over 40%, we recommend the use of mineralocorticoid receptor antagonists to reduce the risk of heart failure hospitalization. And this is a strong recommendation, and we went from moderate quality evidence before fine arts to high quality evidence with fine arts. Moving on to ARNIs, for the sake of time, I won't spend too much on this slide, just to say that this is one of the key studies looking at sacubitril valsartan in heart failure with non-reduced ejection fraction. They randomized many patients, almost 5,000, and basically the primary outcome was not different between the intervention, which was sacubitril valsartan, and the comparator, which happened to be valsartan alone. However, with the eye of faith, if you look at the slide, the figure at the bottom there was less heart failure hospitalizations in the sacubitril valsartan group. And this is just showing it in numbers. I like absolute numbers. So the number of people who had an event, meaning who were hospitalized or died of cardiovascular disease in the sacubitril valsartan group was 894, and compared to 1,009 in the valsartan group. And when you look at how to tease this all apart, basically the benefit was really related to reducing heart failure hospitalizations. Similar to the other slide I showed you, where we pooled the available randomized controlled trial data, when it came to cardiovascular mortality, while the point estimate favored ARNI, there was a wide confidence interval suggesting that there may be a benefit, but there may also be harm or no benefit to ARNI. Whereas for heart failure hospitalization, pooling the available evidence, which included about 8,000 patients, there was a benefit, or the risk of heart failure hospitalization was lower with ARNI, and that was it was such that the confidence interval, or what we believe to be the truth, favored ARNI even at the upper confidence interval. So what was the summary recommendation for ARNI? For patients, or for people with symptomatic heart failure, and an ejection fraction over 40%, who are at low risk of symptomatic hypotension, and due to the sake of time, That qualifier was something we felt was important to include in our recommendation, speaking to the desirable and undesirable effects of the medications we prescribe for people with heart failure. We suggest the use of ARNI to reduce the risk of heart failure hospitalizations. And this was a weak recommendation when you take into account the totality of what is in the GRADE evidence to decision framework based on moderate quality evidence. So I will now pass it over to Mike, who will go through the other 2 PICO questions.
Thanks, Natasha. So similar, we'll frame this with a case in similar fashion. So for your consideration, we have a 66-year-old female referred for peripheral edema, breathlessness, and severe symptom burden after a recent emergency department visit. She's got a history of hypertension, obesity with a BMI of 31, impaired fasting glucose. She's on candesartan, spironolactone, and furosemide. She examines, again, a little bit edematous and volume overloaded with structural heart disease in the form of concentric remodeling, an EF of 55%, with moderate tricuspid regurgitation and an RVSP of 40. That supports the diagnosis of a heart failure syndrome. And natriuretic peptide levels are up, and renal function is reasonable. So again, is there a role for additional pharmacologic therapy, specifically addressing the SGLT2 inhibitor story and GLP-1 receptor agonists? Would this patient and this STEM benefit from either or both of these drugs? So again, not to belabor the evidence, but just to show you a couple of important examples in the literature. This was a study of almost 6,000 patients, familiar to many, called the Emperor Preserve study. And this was empagliflozin, 10 milligrams a day versus placebo with about a 2-year follow-up. And there was an important reduction in the combined endpoint of cardiovascular death or heart failure hospitalization, and a more impressive reduction when we just look at the heart failure hospitalization burden. In nearly identical fashion and identical design was the competing product, dapagliflozin, 10 milligrams a day versus placebo, 6,000 plus patient study, EF over 40% with a heart failure syndrome, looking at nearly identical outcomes, worsening heart failure events and cardiovascular mortality with nearly identical findings. There was a significant magnitude of reduction, over 20% of worsening heart failure on treatment compared to placebo. There are a few other smaller studies, but certainly those two were the biggest drivers in the systematic review and meta-analysis, and you see a pretty important and impressive reduction of about 25%, 24% in the risk of a heart failure hospitalization. There are, of course, quality of life metrics embedded in these studies, and when you meta-analyze the data, we see an improvement, a statistically and clinically meaningful improvement in quality of life as measured by KCCQ symptom score. So, as Natasha said, without exaggeration, after many months of work and synthesis, this is what the recommendation looks like. And it's important because it's a strong one. So for people with symptomatic heart failure and an ejection fraction over 40%, we recommend the use of an SGLT2 inhibitor to reduce the risk of heart failure hospitalization. Again, strong recommendation with what we felt was high quality of evidence now. There are some important value considerations. So in the text of these documents, there are always nuances, and the text of guidelines get at more of the nuances than sometimes the graphic figures do, which are oversimplified. But important values is we don't have a lot of data on the perspective from people with lived experience taking these medications, and we don't have good data yet on the cost effectiveness of these interventions. So what is the cost effectiveness? How many quality life years do we add, keeping people well and out of hospital for the cost of these medications? So those may be modifiers as you sit down and have conversations between patient and prescriber. So the GLP-1 receptor agonist story again is incredibly buzzed about. It is a very topical and has tentacles in all areas of cardiovascular medicine and atherosclerotic disease, metabolism, and of course diabetes. But specifically looking at two populations, or were twin studies by the same investigator group over the last couple of years, that looked at randomizing patients with heart failure and preserved ejection fraction. One was the HFpEF trial. So these were patients without diabetes, with an ejection fraction over 45% and a BMI over 30. And they were randomized to semaglutide, also known as Ozempic, targeting a top dose of 2.4 milligrams a week. For those who prescribe, know that this is a pretty high dose, and most patients achieve that dose with acceptable side effects, versus placebo. And the primary outcome was a change in quality of life markers, the KCCQ, and a change in body weight. Secondary outcomes were the heart failure events, how far people could walk in 6 minutes. So if you look at the key results of this trial, the bottom figure indeed shows a substantial reduction in body weight. People on the treatment arm lost about 13% of their body weight. I should mention over about a year follow-up, and compared to about 2 or 3% change in body weight for people in the placebo arm. And then there was a significant difference, a mean difference of nearly 8 points on the KCCQ clinical symptom score, which is, again, clinically significant. If you look at the HFpEF diabetes trial, same exact thing, but this time in a population of patients with diabetes. And again, you may ask, why were they parsed out? And that's because patients with established diabetes don't seem to lose as much weight on these medications as patients without diabetes. And so the clinical outcomes may be different in this population. There are also different event rates if you have diabetes or you don't have diabetes. So this is over 600 patients with a heart failure syndrome, EF greater than 45%, BMI similar, identical actually, greater than 30, and they had established diabetes. Same intervention versus placebo, same outcomes. And this is what the results looked like. Again, there was a more modest but still impressive reduction in body weight, so about a 10% weight loss or change in body weight in the treatment arm compared to 3%, 3.5% in the placebo arm. And there was, again, that same magnitude of clinically significant, important difference in the quality of life measures in this patient population. Again, heart failure events were secondary outcomes. So how do you put that in the stew and come up with some sensible recommendations? Well, you kind of look for events and you do the systematic review looking at that important heart failure hospitalization question. And again, in the preserved ejection fraction population with these agents, you see there is a significant benefit to reducing heart failure events, again, with somewhat wider confidence intervals, but still statistically significant. So it seems that there is at least a modest signal that these medications not only make people feel better, they lose weight, but they're less likely to be hospitalized. And then in the discussion that follows, I'm happy to talk about why people think that is the case with this class of medications. So again, what is the recommendation that flows from that evidence? So this is how it reads, and will read in the paper, the manuscript that's published next week. For people with symptomatic heart failure, an EF of 45% or more, and a BMI of 30 or more, we suggest a GLP-1 receptor agonist such as semaglutide to reduce the risk of heart failure hospitalization and improve quality of life. For the reasons that Natasha outlined, this would fall in the weaker recommendation, requiring some discussion with patients at an individual level with moderate evidence base, moderate quality of evidence. And there are a number of value considerations for this as well. So this assumes by people who author guidelines that most patients will place a high value on weight loss and reducing the risk of hospitalization, balanced against the need for another medication and one that's injectable that you have to take weekly. The cost effectiveness is not well established, particularly for reducing heart failure hospitalizations, and probably most significantly for frontline prescribers. massive challenges related to equitable access to the medications in Canada, at least in 2025. So just to summarize, a lot of information that has come at you in the last few minutes. There is evidence to reduce heart failure hospitalization with 4 categories of medications, and for at least a couple of them, some evidence that it improves quality of life measures that were studied, and 6-minute walk test as a more objective marker of functional capacity. Why are we so excited about reducing heart failure hospitalizations? Because it's associated with disease progression and more morbidity and ultimately mortality, and of course impact on quality of life. It is heart failure hospitalization, as we know, is incredibly resource intensive and is the biggest driver of healthcare expenditures. We now have treatments that can reduce this outcome, the risk of this outcome, and heart failure hospitalization is incredibly common. So we think this will have meaningful impact at a patient and population and systems level. So you may be familiar with the HFrEF proposed treatment algorithm. This is a first look at what will be published as the proposed treatment approach to reduce heart failure hospitalization for people with non-reduced ejection fraction. So if you have symptoms and your EF is over 40, the strongest interventions we can offer right now are mineralocorticoid receptor antagonist and an SGLT2 inhibitor. And then depending on the patient phenotype, which is getting into a little more personalized and sometimes nuanced decision making, if we have patients with elevated BMI, we can use evidence-based GLP-1 receptor agonists. And if you have an EF over 40% and you are at low risk of hypotension, you may value the addition of an ARNI to your to treat patients with heart failure and a preserved ejection fraction syndrome. But these are weaker recommendations. On the sidebars, longitudinally, is all the disease management stuff, managing volume with diuretics, and then co-interventions for things like atrial fibrillation and valve disease that is out of scope for the session here. So none of this matters if it's not important to patients, and what we think as clinicians, we may not be reflected in what our patients and people with the lived experience have to say. So I'm going to invite Anita up to share her thoughts to close us off.
Well, thank you, Drs. Mike and Dr. Natasha, as I call her, because I feel close to her. She's amazing. All I have are stories to tell. It's been a long time since I've stood up in front of a large group and spoken, so I've lost a little of my mojo, and you guys are all really awesome, so I'll do my best. The truth is, all I have are my stories, and I hope there's some value in them. At first, when I received Mike and Natasha's slides, I thought, well, what can I possibly offer? And the truth is, I wrote and said, could you ask me a few questions on which I can focus my thoughts? And they did within 30 seconds, and it was on the weekend, so just so you know, they're on the case all the time. And the truth is, what I can offer are my stories, and you'll infuse them with whatever value makes sense to you. The first question was, which side effects matter most to patients? And of course, you named all the factors that come into play there, but what matters most, you have to understand from the patient's perspective. I'm sorry, I do need to use my notes, and then I need my glasses, and it's the way it goes when you're 77. So my assumption is you ask that question because you would really like your patients to follow your recommendations and to take the meds that you prescribe and they agree they'll take. But you need to understand what will drive them to take them. Is it anxiety? Is it fear? Is it quality of life that they already are not feeling? Is it guilt, the sense that they know they're a burden on their family and therefore they'll try to do something about that? And in the clinical context, I think what that requires is for you to ask questions, to understand the patient. Ask them, so what's important to you these days? What do you love to do that you can't do? What do you wish you could do? And these might seem wishy-washy, and they do take a little more time, and you probably don't have a lot of time. I do recognize that. But that's how you might get at what would work for you to say so that you can influence them to do what you know in your heart is best for them. And so the next thing is to understand the risk versus the benefit from their perspective. And you spoke about that. That's clearly something that occurs to you. And then you go to what side effects matter to the patient. Some matter a lot, some not so much. I'll give you some examples that come from the three shadows that persist in my life. I have rheumatoid arthritis, which came on 2 weeks after I had too many vaccines. I was headed on a trip to India for Ryerson at the time. I was trying to increase the use of our nursing online programs in that country, which would have been very useful for them. Sadly, it was January. The travel doc said, well, why don't I give you your flu shot at the same time? That's a live vaccine, I believe. Within 2 weeks, I couldn't use my hands. Maybe that was meant to happen anyway, but in my head, that's what caused it or brought it on. And so my fear of inability to use my hands and the pain that was caused by that meant that when I went on Plaquenil and sulfasalazine, I took them for 13 years without questioning my rheumatologist. Is this still okay for me? I suspect by now you know there were likely some side effects on my heart from that. So that speaks to the concept of needing to review the orders. Am I on the right slide here? I think I am. Another side effect that was really tough for me is the respiratory distress that was caused by the palpitations that eventually turned into atrial fibrillation. When I had the serious AFib, I honestly thought if I have to live like this, I would prefer to die. I love to be active. I love movement. I love the ability to do things. And I couldn't do anything. It came on in the night when I would wake up to go pee. We would stay for days. And if it was only eventually when I went to Sunnybrook, emerge 3 times in 1 month that my electrophysiologist, who was brilliant and really helped me, he said, well, first of all, I've missed a spot. Before I got to the atrial fibrillation, the palpitations were such that I was put on a Holter monitor, and the electrophysiologist called and said, your heart missed a beat for 4 seconds. You have to stop driving. What? I'm 70% sure you need a pacemaker. What? Me? Are you kidding? And he used the metric. And he said, look, 4 seconds, no beat. You can have a terrible accident and hurt someone or impair yourself for life. And within a very short time, I went from the wait list of 14 months to being offered an ablation 2 weeks later. I had friends who had unsuccessful ablations. So I asked, well, what are my chances of success? He said, given your age, given your RA, given all the other factors at play, I'd say 70% likelihood of success. I thought, okay, I can live with that. Go ahead, despite all the stories I had heard. So using the metrics really helped me. On the issue of the Plaquenil, you'll know better than me whether that contributed to the congestive heart, but I do believe I've read on this Google version that patients read that probably it did. So the research you all do, the research you do, and having clinicians who aren't engaged in research, it's really important that your research findings reach them. And I don't know what the lines of communication are between the research specialists and the clinicians, but I would hope that they can be strengthened. You asked if reducing hospitalization is sufficient for patients to want to take meds. Well, I don't mean to be repetitive, but I think I need to be. That is an impact that is named from the physician's perspective. You understand, I read in your slides that results of hospitalization are not great. Apart from the expense, they don't necessarily lead to the good results we would all wish for. So what would make more sense to the patient? And that's to go back to the drivers of the patient's behavior, which I spoke about before, but to go to the day-to-day and to say, if you take these meds, you'll be able to walk better. You'll be able to walk up the hills when you're trying to do a hike. You'll be able to not have swollen legs, so you'll be able to get on the subway and get to work. Or you'll be able to cook a meal when you get home from work. Or for younger patients, you'll be able to pick up your children and your heart won't be all compromised. It will help. So I think that kind of language speaks directly to the patient's reality in that moment. Generally, as patients, we think, well, if I go to the hospital, they'll be able to fix whatever the problem is when I'm there. Hopefully, our COVID experience taught people that that isn't the case. But apart from that, people generally still think what you do in hospital will really work. And unfortunately, it doesn't always as we wish, as you wish, and it's awfully expensive and a burden on the system. So we need different ways of having it make sense to the patient. You need to explain the step-by-step symptoms that will impede quality of life. And back to the way Dr. Crystal, my electrophysiologist, explained it, if you share the metrics, if you share the crayon version of what your slides showed, that'll make sense to the patient, to most patients. And then my last point, think care team. You can't do it all. The burden is enormous on you. You have other people in the care team. Probably not enough of them, but the specialists are the most respected and revered of the physicians, from the physician's point of view and from the patient's point of view, and from all the allied health professionals' perspective. So if you have a line of communication you can establish to the pharmacist, to the GP, and somehow you ask them to work with the patients who perhaps aren't following your recommendations, perhaps that would alleviate some of your burden. I don't know, it's a thought. Hopefully we'll have more care teams They keep promising them. I hope they're happening. You talked a lot about how cost figures in the calculus. So, any actuaries here? No, the cost benefit issue is always tough I worked in the insurance industry for a while, talking about leadership and organization development there. Ask me how hard that was. They don't think in that way, but the way they assess risk and cost benefit is frankly brilliant. That they know how to do. So I have two lessons from my stories, from my life, that will explain how important the cost issue is. One is historical, and it's the story of my family, and the other is more recent, and it's the RA Med story. We came to Canada on a boat crossing the North Atlantic from Egypt in 1951. My father, who was about 46 at the time, maybe, shepherded 10 family members through the immigration process, and we landed in Halifax in December. My parents had never seen snow. My mother, who was 11 years younger than him, turned to him and said, "This is where you brought me?" And we went to Montreal. French was our first language. And within a year of reaching there, despite his enormous talent, he spoke 7 languages. He'd worked in the movie sector, in the film sector in Cairo. He was a musician in the evenings to bolster his income, an incredibly active and talented man, but he smoked. Both my parents smoked. Within a year of coming to Canada, he suffered a major heart attack, and he had arteriosclerosis, which was worse in his legs. This is pre-Medicare days, folks. He was funded by family to have experimental surgery at the Baylor Institute in Houston, Texas. And so right there, you can start cueing the family drama that comes from the cost of that. Move forward to the fact that despite having femoral arteries that were about 1 inch wide, he brought one home in a test tube. They hadn't discovered blood thinners yet. So he had a series of about 11 heart attacks over the ensuing years. In the meantime, my mother, dealing with the stress, developed ulcers, had a nervous breakdown. Our family was shattered. My father couldn't afford the medications, and he died when I was 18. My mother was unable to help me fund my graduate school, and my sister, who was 5 years older than me, said, "I'm getting out of here." She went to move to Italy, and she still lives there, actually. So that was the impact of lack of affordability of meds and lack of research at the time. Cost matters. My present day example is when I was lucky enough to get a new rheumatologist. She was able to apply to get me on a biologic, took me off the Plaquenil and the methotrexate. Actually, I'm still on methotrexate in a light dose. And she advocated for me. My previous rheumatologist didn't. When I told her I couldn't afford the $1,800 a month that medication cost, she applied for compassionate care. And I was able to access that for 3 years till the drug was brought onto the ODB. So perhaps advocating for more compassionate care programs where it's possible, and let's hope this talk of moving from 13 economies to 1 in Canada would enable you to advocate for Canada-wide purchase of the designer drugs that we all now rely on. those are two advocacy issues that hopefully the care team can help you with, because you can't do it all, but you could sign the forms, I suppose. GLPI. Weekly injection versus a pill. Yes, a pill is preferable. It's really less scary. My biologic, Rinvoq, turns out was showing me having very low white blood cell count. So I guess I was susceptible to infection. Luckily, I haven't had an infection, but my rheumatologist said, we should switch you. I'd like you to try Kevzara. I really listen to my specialists, as you can tell. Kevzara. What's that? I'd never heard of it. She said it's an injectable. Would you try that? Well, that made me really anxious. It needs to be refrigerated. And the whole thought of this switch from a daily pill to a weekly injection that I have to refrigerate, it just made me very upset. But being a good girl, of course I tried it. Well, I developed the worst adverse reaction you can imagine. I had mouth sores. I couldn't swallow. I could barely drink water. I had body rash. Hooray. We had to take me off it. 10 days of prednisone set me right. And then I was back on Rinvoq. But I probably still have that low white blood cell count. So would I take an injection if I knew it was going to help me, if I hadn't had that adverse reaction? Yes, I would. But I need help dealing with it. I will say there was a Kevzara, I hope I'm getting the name right, care nurse. I watched the videos on how to give yourself the injection. Luckily, my partner's a 30-year diabetic, and he kept saying, I'll help you, relax. So there is help out there, but it's a transition. All of this is about helping your patients manage change. It's all about how do we adapt to change. And back to the risk-benefit thing, if you told me that what I'm taking would help me lose the 10 pounds my electrophysiologist still thinks I should lose, well then, yeah, sure, I'd work with it. Cost benefit. End result, identify the positive drivers, share the metrics, talk about the improvements to quality of life. You have all that in your graphs. You know all this. It's about how it comes out in the clinical setting. And you're so rushed. I see the lines waiting to see Dr. Natasha when I'm at the hospital. It was probably worse when I moved to UHN with you. So again, we're back to the care team. It's important to understand what will influence the patient, because what you have to offer is just a little bit short of magical. And I get it. I'll work with whatever you say. Not everybody is able to. There's a lot of chaos in people's lives these days. So if you can seek to understand what will move them, I think we're away to the races. That's it. Thank you.
Thank you so much, Anita. We started a couple minutes late, which and we've just got a couple minutes for questions, and it goes without saying, thanks so much to Anita for sharing and Natasha for presenting with me. Ping, go ahead.
Hi, my name is Ping. I'm a pulmonary hypertension fellow. I'm also a cardiologist. So I work with Dr. Van and Dr. Peng in the pulmonary hypertension today. And we actually saw a lot of referral with patients with increased RVSP. And this week, there are some two patients, all of them are similar in that case. We probably have half, but they refer to the PH clinic. And I just want to ask you, in the new guideline, there new incorporation of like diagnostic criteria for HFpEF. I know there's a new guideline from the American Society of Echo, which came out in July 2025 about the new guideline for diagnosing HFpEF and diastolic dysfunction. Just wondering, in the new guideline, do you have anything different or similar?
No, not in particular. I mean, there's some text around what constitutes a diagnosis of HFpEF, but it's not intended to redefine the diagnosis of a heart failure with preserved ejection fraction per se. It's really assuming you've got an accurate diagnosis. What are the recommended treatment approaches? But yeah, that's a whole other and more nuanced thing. Heather, then Phyllis.
Yeah, thanks so much, Ross, cardiologist. So that was tremendous, Anita. Thank you. Really appreciate it. And you mentioned something about the duration of your rheumatoid arthritis care, which had me thinking about the GLP-1s. And those studies are short. And we well know that when people stop the GLP-1s, their weight gain largely comes back over that time. We know that there's probably tremendous inflammatory issues that happen fact. So I'm just wondering about the recommendation, because we don't have long-term data, and how long, the other medications, when we start them, we're basically recommending for life.
Yeah.
So how are we, and how did that thinking come into your GLP-1 recommendation?
Yeah, so very important, and it's one of the acknowledged limitations. That's why it is a weak recommendation, and one of the other critiques that we will get and have had internally is the discussion about tirzepatide, which is a mixed receptor agonist, with the Summit trial showing, even more impressive clinical outcomes. So, there is this groundswell of momentum for this class of medications, and interestingly, this is one that we have heard that the patients are asking for more than others, because weight loss is more important for many people than treating a heart failure syndrome. So these are drugs that don't need a lot of marketing, and so the responsibility of looking at longer term data still falls to the scientific community because we don't have it. So yeah, very good question. Phyllis, and it sounds like Phyllis gets the last question and maybe the last word. Yeah.
The question really relates to cost, because the GLP-1 receptor antagonist, if you don't have diabetes, is not covered, and it's not a cheap drug. So is there advocacy from our different national agencies to see about how we can get that on the ODB or other ways, get it just to make it a little bit more affordable so more patients actually can go on it?
Yeah, 100%. We recognize that's probably the biggest barrier. And, one hopes that as the data accumulates, the cost effectiveness data hopefully follows, that then you have an argument to get broader coverage. This is the biggest limiter. So, philosophically, a guidelines panel has always just tried to report the evidence irrespective of availability and cost. And if you think of other drugs like vericiguat and even eplerenone back when it was first available, you just report the evidence and then acknowledge that accessibility is an issue. And then you hope that drives advocacy. Can't do it all through the guidelines, but the broader Canadian Cardiovascular Society, Canadian Heart Failure Society, HeartLife, we have a lot of patient partner organizations that we collaborate with. That is where the advocacy is needed and often comes from. So maybe a good place to end, because I'm also getting signs that we're at time. But thanks so much for coming. Happy to stay back and answer a few questions too.